Palliative Care Network lecture series for 2015, the master lecture under the auspices of the European Association for Palliative Care. I'm Geeta Lamba, and this session is titled Emergency Department and Palliative Care. I'm an Associate Professor of Emergency Medicine, the Associate Dean for Medical Education at Rutgers, New Jersey Medical School in Newark, New Jersey. I'm board certified in emergency medicine, internal medicine, and hospice and palliative medicine. And my major interests and research and truly my passions in education are teaching and assessing of palliative care skills, mainly communication skills in the specific settings of trauma and emergency medicine. And again, this would include the undergraduate and graduate medical training. One of the major roles that I've been engaged in has been over the past year and a half in developing palliative care milestones for the emergency medicine residency training in the United States. And this is part of two major roles that have been part of my career in, again, the same time span. One is as the chair-elect for the Palliative Medicine section, the American College of Emergency Physicians, and the second is as chair for the Emergency Medicine Forum, which is kind of like a special interest group for the American Academy of Hospice and Palliative Medicine. And the third main interest that I've had has been in the integration of palliative care into routine emergency medicine practice. And this came about as part of my role as the IPAL-EM advisory expert for the Center to Advance Palliative Care. I have no conflict of interest or funding sources to declare. And quick roadmap of this session. The goals and objectives are at the end of this session, you should be able to describe the importance of and challenges to ED palliative care, list some of the U.S. models of ED palliative care, understand the evolving concept of the generalist and the specialist levels of ED palliative care. Then I'll also identify some ways, the 4 key ways to help jumpstart the process of ED integration of palliative care in the individual institution. And finally, identify some quality measures that track the outcomes of any integration initiatives that are initiated in the institution. So to get started, the emergency department. And the first question is, how in the world can we do palliative care in this kind of environment? But as an emergency physician, this is the field I chose. This is my reality. This is a reality for a lot of emergency medicine physicians. And what we recognize is the number one reason people come to the ED is because of suffering or pain. We can do better, and we have to do better, because the majority of patients that we care for are not coming in for acute illness, but they're rather older adults or people with chronic illnesses who are coming in to us with acute exacerbations of chronic illness. And one of the well-known facts is that this population is only going to increase in numbers. So part of ED palliative care is understanding the ED culture and its challenges and its opportunities. So some of the challenges for the ED culture are pretty obvious. It is a resuscitation-based culture. We're very used to dealing with acute care, life-sustaining, life-prolonging interventions. Overcrowding, chaotic environment, long wait times, and practice is a high distraction. It does not give you time to sit down and have a conversation for lengthy time with a family. There's high medical legal risk associated with it. And because it is a volume-based specialty which provides care for all comers, the currency in the emergency department is speed and throughput. Also understanding the fact that in the emergency department, there are national pressures on ED quality core measures. To give you an example, for a stroke, it's time to CAT scan, time to TPA or thrombolytics, time to cath lab, time to an EKG. These are all challenges placed in providing care in the emergency department. However, what I want to highlight more is the opportunities. The emergency department in general has been a place which has always historically been receptive to new ideas, whether it is taking initiatives in domestic violence, smoking cessation, HIV screening, collaborating with multiple other specialties. This is a specialty and a group of physicians that really take pride in patient advocacy. The emergency departments are usually safety nets for our vulnerable patients, and we may be the only people who provide the voice for them in the healthcare system, and we take this very seriously. Another aspect is emergency medicine physicians tend to be problem solvers. They try and handle it themselves if they can and not bother others, but recognize that we're very used to working in a collaborative team culture, and this team spirit makes it quite easy for us to engage with other specialties and other collaborative efforts. And one of the most important things is that the emergency department, like I mentioned, is really focused on symptom management. We recognize that you may not know the ultimate diagnosis for a patient, but you can always do something to palliate symptoms or to control symptoms. And pain happens to be the number one symptom for which people come to the ED. So why think about palliative care in the emergency department? Like I mentioned, it's often the initial point of contact with the patient. They may not have sought primary care previously. It is an opportunity to intervene during a crisis. Things that may seem obvious to patients are really highlighted when they hit the emergency department, and this is a time where teaching moments are provided, where you can really make a difference in how people think about their disease and the management of disease. For the critically and seriously ill patients, this is the stage setting where key decision points are made. Will the patient be admitted? Will they be admitted to the intensive care? This is often where life-sustaining treatments are initiated, pressor support, placement on ventilators. So palliative care can and should be moved upstream into the emergency department. And hospice and palliative medicine is actually now a subspecialty pathway for emergency medicine and emergency medicine trained physicians. There's been a national focus for the emergency medicine discipline on palliative care and hospice care. The Choosing Wisely campaign from the American College of Emergency Physicians announces and has announced lists of tests as part of the Choosing Wisely campaign, and one of them is, it's listed here: don't delay engaging available palliative and hospice care services in the emergency department for patients likely to benefit. An early referral from the emergency department to hospice and palliative care services can benefit select patients, resulting in both improved quality and quantity of life. This puts emergency department palliative care or emergency palliative care actually on a national stage for emergency medicine. So talking about the fact that this is something that needs to happen, is happening, and is happening in larger numbers across United States, one of the things that we undertook was to understand, as part of the IPAL-EM initiative, is to understand what are the clinical initiatives that are currently in place in emergency departments to improve palliative care in the emergency department. And as a result of that work, multiple phone calls and conversations across the nation, we found 4 levels of engagement or models or clinical initiatives of ED palliative care. And these start from the left to the right, with the intensity of ED engagement in palliative care increases as you go from the left of this table to the right. So the first level is a traditional consult model, which is palliative care service is partially or fully available if called from the ED for a consultation. And in this model, there's no specific initiatives, programmatic goals, and much cross dialogue between the two specialties. The next stage, which is more common, is the basic engagement, where there are some mutual agreements or initiatives regarding the process and function. There might be some mutual workflow arrangements like admissions directly to a palliative care unit, let's say. Level 3 becomes an advanced engagement model. Here there are, to give you examples, perhaps a collaborative set of palliative care triggers that the emergency department uses to initiate palliative care consults. And we'll talk a little bit more about the emergency department triggers in a couple slides coming forth. They may have, at the advanced engagement level, some education and quality improvement initiatives or partnerships, and may even work on some focused assessment and documentation tools that support the quality initiatives. And then the most advanced is the ED advanced model, where there is intense level of generalist palliative care that is provided by the ED routine practice. They may even be, and in most of the programs who are ED advanced models, there is an ED palliative care subspecialist who may be board certified in both emergency medicine and hospice and palliative medicine that exists in the emergency department. And there are definitely more levels of partnership with the hospital offered palliative care services or programs. So this is the usual way you may see the practice of ED palliative care in the United States. So one of the terms that has been evolving in the recent couple of years has been the generalist versus specialist levels of ED palliative care. It is becoming quite apparent that the workforce for hospice and palliative medicine is not going to meet the demands of the patients. Certain level of care, skilled palliative care, has to be provided by the first line providers, and in this case, the emergency medicine physician. So when I mean the generalist level of palliative care, I mean it's the care that's being provided by the emergency medicine physician who has had no subspecialist level of training for palliative care, but has the basic skills and competencies that are required for all emergency medicine physicians to target effective communication, good symptom control, and basic level of decision making with families. That would be palliative care skills that are practiced at the generalist level of palliative care. So in one of the original articles published about hospice and palliative medicine and emergency medicine, there were some generalist level of ED palliative skills that were identified. And I list them here, the 10. And these are skills that each emergency medicine physician, pretty self-evident, determining the illness trajectory and prognosis, communicating sad, bad, and difficult news, formulating and even interpreting advanced care plans, symptom management we discussed, withholding and withdrawal of non-beneficial treatments, managing the imminently dying patients, understanding the ethical, legal, spiritual, cultural aspects at end of life, and allowing for family presence during resuscitation. Now I'm going to talk a little bit about the specialist level of ED palliative care. So this would be palliative care that is provided more on a consultation basis or by faculty, staff, and clinicians who are who have had further training in palliative care. And usually this would be an ED initiated process for examples which I list here, which is difficult to control symptoms. So pain that is not being managed by the routine processes of ED care. Perhaps the family requires more complex decision making or resolution of conflict of goals of care at the end of life. Management of an actively dying patient. Often assistance is needed for family support when we withdraw non-beneficial treatments such as terminal extubations. Often, specialist level of care is needed for bereavement support of families. And this is more often seen when there's a sudden death in the victim of trauma or an unexpected death of a child in the emergency department. And finally, the specialist level of emergency palliative care may be necessary when there are challenging dispositions that require a much higher level of care coordination amongst institutional, perhaps community resources, such as placement of a patient in hospice for the first time. So, all of these processes of doing emergency palliative care would require some mechanism for identifying patients or selecting patients who would benefit from these early palliative care interventions. These could be called triggers, screening criteria. And in my mind, there's two subsets of patients that the screening of palliative care. One is the newly identified ED patients. These are patients who come in, have never had a conversation or thought about the palliative care approach to care. And the second subset is patients who are already in some way under the care of palliative care experts or under hospice care who still seek the emergency department for a crisis event. So when I mean newly identified ED patients for palliative care consultation, some examples would be older patients who have multiple comorbidities, such as the frail elderly patient with advanced dementia who's coming in from a long-term care facility, patients with advanced malignancy, perhaps malignant bowel obstruction, advanced chronic pain concerns. Neurological conditions are often newly identified ED patients who would benefit from early palliative care consultation. And neurological conditions include both the devastating acute neurological events, such as a massive stroke or a massive inoperable intracranial bleed. But they also include chronic conditions, such as multiple sclerosis, perhaps Parkinson's disease, where there's been a steady declining clinical status and poor outcomes, poor prognosis, poor quality of life indicators. One subset to consider for early palliative care is those patients who have had resuscitation after a cardiac arrest. And then the last subset is the organ failure, which happens to be a very difficult subset to identify in the emergency department. And what I mean by that organ failure would be advanced congestive heart failure, end-stage COPD, chronic obstructive pulmonary disease, end-stage liver disease. And then the second population that I talked about are those patients who are already under hospice or palliative care. So why do patients under hospice care visit the ED? Now, this has been shown in practice that it's usually because of poor symptom control, mainly pain and shortness of breath. Often there's malfunction or loss of support devices like a tracheostomy tube or a gastrostomy tube. But most times the presentations for hospice care patients in the ED are not physical distress. It's usually stress, fear, inability to cope, maybe having conflict with their caregivers about life-prolonging treatments, maybe having competing philosophies of approach of care. The caregiver may want more aggressive care, the patient may not. The caregiver getting fatigued from caring for an intensely or addressing the needs of a very seriously ill patient. Often it's just an automatic ingrained response to perceived distress. And then occasionally you may have equipment failure, or the person who's supposed to be on call for the hospice may not be able to address the patient needs in a timely manner, or there might be a slight delay which encourages them to come to the emergency department. The screening for ED palliative care is a process that is ED initiated. And usually it starts with three major things that I feel are important for the ED clinician to consider. Perhaps the most important and easiest one to address would be the surprise question. The would you be surprised if this patient were to die in this hospital visit, in the next month, in the next 6 months? This question actually forces ED physician to integrate patient's comorbidity, clinical status, social status, other factors, and it's a clinical judgment question which is quite important when starting the process for screening eligible patients for early palliative care in the ED. Often it's a choice or a need conversation. So the seriously ill patient may make a choice for comfort care only, and then the ED should be prepared to support that choice. And occasionally there's a special need for palliative care for a very complex end of life issue such as malignant bowel obstruction. And then, along with the conversation of understanding, is there a choice, is there a need, is there clinical judgment that supports it, certain clinical indicators may help the emergency medicine clinician, such as indicators of advanced disease, if there's imminent worsening of condition. And one of the ones that's easy to grasp is patients who are seriously ill who are requiring interventions such as ventilator and pressor support, but there's a recognition on the part of the ED clinician that these aggressive interventions are probably not going to benefit the patient or change their short or long-term outcome on the hospital visit. So once these considerations are in place, the ED, perhaps with the palliative care team, may want to consider triggers or screening criteria to have this early identification process for patients for specialized palliative care services or linking them to the adequate resources. So, based on one of our recent publications in the Journal of Pain and Symptom Management, we did a review of literature on palliative care screening and assessment in the emergency department. And the table that I'm going to present to you in the next couple of slides is based off of our conclusions on this systematic review, so a few things that we recommend when you're thinking about establishing screening criteria or triggers in the ED. We recommend that the time to screen should probably not create a lot more work on the part of routine processes of the ED. So it probably should be a couple minutes at the most. The person who performs screening should probably also be an ED personnel, such as the ED triage nurse. And again, preferably no additional resources to be taxed in the emergency department. One of the things we recognized when we did the systematic review is the fact that the first tier is an ED-based or emergency department-based screening process. And if there's a second tier or a third tier, those detailed assessments are best when they are conducted by other qualified personnel, such as a social worker, or in some cases, in some studies, it was a palliative care nurse or a designated person who did advanced level of screening. We spent some time talking about the target population. Most studies that we looked at had elderly patients over the age of 65 and or patients with a chronic life-limiting illness that they identified as their target population. Our suggestion actually would be that each ED identify their own target-based population, and it may depend on what institution you serve. If you're at a major cancer center and tend to provide service for a lot of patients with malignancy, then it obviously that subset of advanced malignancy may be the target population for your setting. Meanwhile, if it's a heart failure center or a end-stage liver disease transplant center, then that may be a population that you want to target for establishing triggers or screening criteria. Like I mentioned, having educating the emergency department and perhaps the clinical staff on the would you be surprised question, um, which would be a very good initial screening tool, is also recommended. Adding on some of the special considerations, again, functional status of the patient, what kind of caregiver support, perhaps frequency of them visiting the emergency department and frequent hospitalizations may be good, but it may be quite necessary in those cases to actually set some criteria which help the ED clinician identify some definitions of what this means or what we mean when this is considered a criteria for screening. And then I'll talk a little bit more about the outcomes of the screening process, because if you initiate a screening process or screening criteria in the emergency department, assessing your outcomes may be one part of improving the quality and assessing the impact of your intervention. Perhaps the completion rate of tool, how many people screened quote unquote positive for palliative care referrals, how many were referred to in hospital or community resources, what was the nature of intervention, what was the time to disposition, how adequate was their symptom control, if patients were referred early to palliative care, did that improve patient and caregiver satisfaction. So those are all elements to consider when designing or creating a trigger tool or screening criteria for screening patients in the emergency department. The next thing we're going to jump to is what do we do? What are the 4 things to do to jumpstart ED palliative care? And this has come out of the work for the IPAL-EM initiative. And the 4 general steps, more information is obviously available at the capc.org site. The first step is to identify your ED palliative care champion or your partner. This would be one person who in the past has expressed an interest in palliative care, has come up to either be worried about the care that was provided on a particular patient, is passionate about making a change, but having a voice in the emergency department when you're starting initiatives is extremely important. A review of the existing literature, what are the models of care, and this literature in emergency palliative care is exploding. Over the last 5 years, there's been more and more studies coming out with models, with interventions, and showing evidence of how people have implemented ED palliative care and what their outcomes have been. Also equally important is perhaps to identify your own emergency department and institutional resources. And then having a plan for figuring out what the needs of your department are, of your institution are, and starting the conversation by targeting and addressing one need at a time. And again, because it's a collaborative effort, I really want to emphasize the fact that considering what the emergency department needs when establishing initiatives is more likely to have long-term success. And once you've started the process of screening and you've started the process of ED integration, I think one of the most important parts to again get institutional buy-in and to get more support and to show proof of success is to make sure that your initiatives has some outcome measures that you will look at, some metrics. These could be operational metrics, clinical metrics, or customer service metrics. And to give you an example of clinical or operational metrics would be perhaps the emergency department length of stay. How many people went to the ICU or the palliative care unit? How many were referred to hospice after the initiative started? What was the number of ED referrals for palliative care once you started an educational initiative or a screening process? what was the time to palliative care interventions in those who had a consult called from the emergency department. And obviously the customer satisfaction metrics, which speak the universal language for all departments and institutions who want to improve that. Perhaps the percentages of patients who report excellent pain and symptom management, or the percent of families who report excellent end of life care after a patient dies in the emergency department. These would be some suggestion of metrics that could be used for measuring the outcomes of your initiatives. So finally, to end my session, I think the keys to success for emergency department palliative care is twofold. One is understanding the culture of your own emergency department, and the second is collaborating and making it easy and not adding additional work to a very time constrained, high distraction practice area. So, some examples that institutions have used to do successful palliative care ED integrations are perhaps in the understanding the culture phase is the palliative care team member spending half a day in the ED just shadowing the staff, understanding how things work, what's important to them, reviewing some of their symptom management policies and protocols, helping them adjust these policies and protocols, perhaps gathering with the key emergency department staff and nursing for a meeting to learn, what are the common needs around care of the seriously ill patient in the emergency department, and perhaps even assisting to develop or facilitating ED processes. So, for example, there may be a bereavement pamphlet with resources that is used in an inpatient setting that could be translated into care for the dying patient or the family survivors of a patient who died in the ED. Maybe setting up debriefings for some very difficult scenarios, such as for the staff who's caring for an unexpected death of a child, because some of the end of life concerns not only affect the patients and families, but have a major impact on the staff in the emergency department who cares for these patients at end of life. And when I say make it easy and collaborate, what I mean is having some collaborative protocols, making a list, let's say, of community hospice resources that's easily accessible to the ED. Maybe a pocket card with the palliative care team's contact information. Ensuring that the ED understands that if you do not have a 24/7 in-person support, what can the palliative care team provide at a specialist level of care? Would it be phone support? Would it be phone support till a person arrives in an hour? Which ones would they be able to provide full support for in person? Emergent conditions, urgent conditions. So that conversation, having information handy, can go a long way in making an emergency palliative care collaboration be much more cohesive, be much more fruitful, and ultimately benefit patients by early referrals to palliative care. So the potential for providing palliative care in the ED is limitless. It only depends on how effective we can make this partnership. In the next decade, the field of emergency palliative care is going to grow leaps and bounds.